Howdy, y'all. This is Dr. Jeff Jarvis. I'd like to talk with y'all today about an important aspect of making intubation safer for our patients. Now, as y'all know, RSI, or rapid sequence induction, or rapid sequence intubation, depending on how you say it, is the use of both a sedative and a paralytic to facilitate intubation. Now, the literature is clear that the use of paralytics improves first-pass success rates, but it can also come at the cost of profound hypoxia. To avoid this, proper RSI includes adequate pre-oxygenation. After looking at the scientific literature on this topic, I learned that we often don't achieve adequate pre-oxygenation. My review of the literature identified several specific techniques that have been demonstrated to be effective. I put together a clinical bundle of care that is aimed at achieving appropriate pre-oxygenation to increase first-pass success without hypoxia. We implemented this bundle at my prior services, and we published a paper demonstrating its impact on avoiding peri-intubation hypoxia. We're now implementing this bundle here in Fort Worth. The short version of that study, it works. Now, in this video, I'm going to go over what the literature says about the extent of the problem, as well as the evidence for each specific component that's in our clinical bundle of care. I want you to understand why we're doing what we're doing. And then we're going to finish up by going over the results of that paper I told you about that shows the impact of that bundle on the peri-intubation hypoxia rates at Williamson County. Now, when we discuss this clinical bundle, we refer to the entire bundle as DSI, or delayed sequence intubation. Now, while this is a useful shorthand, true DSI is just one component of the overall bundle that we're going to be using. It's just easier to say DSI than clinical bundle of care. Now, before I jump into the literature and get all nerdy with you, I want to talk about a case. Now, I've changed any part of this story that might possibly identify the patient, but please know this was a very, very real case, and it was a case that had a big impact on me because I feel like I was personally responsible for this case. So we need to always keep in mind that the concepts we talk about here may seem abstract to us, but they are very real to the patients we're applying them to. And I think this story helps bring that to heart. Now, I want to share this story with you, like I said, because it deeply impacted me and the crew involved. And as you will soon see, it made a huge, huge impact on that patient and their family. All right, so here's the story. Mrs. Smith, obviously not her real name, is a 68-year-old wife, mother, and grandmother. She'd been feeling puny for a few days. Nothing specific, just not right. She starts to get a bit short of breath. Now, because of her history of multiple medical problems, getting a little short of breath isn't exactly unusual for her. She takes her albuterol inhaler, and she continues to take her daily furosemide, or Lasix, just like she's been prescribed. But otherwise, she doesn't call anybody because she doesn't want to bother anyone. Now, unfortunately, her breathing gets worse, and eventually it gets so bad that she feels like she has no choice but to call 911. A medic unit and field supervisor respond to her home, and they find her sitting up in the living room. She's tachycardic, she's hypertensive, she's afebrile. Her oxygen saturation is 90%. They put on a non-rebreather mask while they're assessing lung sounds. They hear some expiratory wheezes. They give her nebulized albuterol and ipratropium. Her pulse ox, unfortunately, does not go up. In fact, it goes down from 90% to 89% to 88% to 86%. The crew realizes the nebulizer alone isn't going to cut it, so they try to put her on CPAP. Now, unfortunately, Mrs. Smith is becoming agitated and confused. She starts trying to push the CPAP mask off her face. She isn't tolerating their attempts to help her. After a brief discussion, the crew collectively decides she has failed non-invasive ventilation, and they proceed to intubate using rapid sequence induction. So they push 2 milligrams per kilogram of IV ketamine, rapidly followed by 2 milligrams per kilogram of IV succinylcholine. Now, Mrs. Smith relaxes and becomes apneic as intended. She's lowered to a supine position on the ground, and the medics begin to intubate her using a video laryngoscope. Everyone's eyes are glued to that gorgeous VL display as what was anticipated to be an easy intubation becomes difficult. Now, I mentioned all eyes were on the display. Nobody, however, was watching the monitor. And if they were, what they would have seen is her pulse ox continued to drop. 86, 80, 75, 60. Mrs. Smith, who initially had a heart rate of 120, she's now getting bradycardic. Her heart rate is dropping faster and faster. 80, 50, 30, 0. Miss Smith is now in a systole. Recognizing this, the medics abort the intubation attempt. They start compressions. They ventilate with a mask. Her saturation gradually improves to 90% and they get pulses back. A second paramedic attempts intubation and is successful. Saturations rise to 96%. Blood pressure, pulse, stabilize. Whew. Man, the medics tell themselves, Mrs. Smith was very, very sick. Sometimes these things just happen. Nothing we really could have done differently. Fortunately, she has pulses back. All is well now. No harm, no foul. Right? Yeah, not so much. Unfortunately, Mrs. Smith never wakes up. She has permanent hypoxic brain injury, and she remains in a vegetative state. That means that her husband, her children, her grandchildren will never get her back. And all because of an unforeseeable and inevitable illness. Right? Was it really unforeseeable? Was it really inevitable? Was it? Mrs. Smith suffered a peri-intubation hypoxic cardiac arrest, a rapid sequenced death. This is not only predictable, it is preventable. By systematically changing the way we approach intubation outside of cardiac arrest, we can prevent this, and we can do everything we can to assure future Mrs. Smiths get to go home to their families. Now, I want you to take away 3 key points from this video. Number 1, peri-intubation hypoxia is common and it is harmful. Number 2, to avoid peri-intubation hypoxia, stop intubating hypoxic patients. And 3, use the pre-oxygenation toolbox to correct and prevent hypoxia. Now, in the rest of this video, we're going to cover the science behind each of these 3 key points. Each of the components of DSI and the supporting science is described here. So let's get to the first point. Peri-intubation hypoxia is common and it is harmful. Intubation has been a part of paramedic training since the very first national standard curriculum, way back in Freedom House days. Now, we typically teach this as a series of P's: preparation, pre-oxygenation, pre-treatment, and paralysis. Unfortunately, most of these P's have been glossed right over both in training and in practice. Many medics, and physicians too, skip straight to the sexy part of inserting the endotracheal tube. They skip right over the pre-ox, the preparation. This disregard for the fundamentals of pre-oxygenation has led to peri-intubation hypoxia to be common both in the field and in the hospital. Now, I'd like to share some of the literature that points this out to you. With a 2003 Annals of Emergency Medicine study of EMS RSI in 54 patients with traumatic brain injuries, they found 57% of those patients had at least one hypoxic episode during intubation, and the majority of these, 81%, were not hypoxic to begin with. And in the majority of those, the patients were felt by the intubating medic to be an easy tube. So it wasn't a function of these being difficult intubations. So what's a little hypoxia, you say? Well, it turns out that 9% of these patients also experienced hemodynamically significant bradycardia, like Mrs. Smith. In a 2018 paper, Walker and his colleagues in the state of Washington found 43% of patients undergoing EMS RSI had peri-intubation hypoxia, and 68% of those were severe hypoxia, 80% or less. The intubation attempt nadir, or low point, for half of those patients was 71, and the 25th percentile for that low point was 36. This means that a quarter of all intubations had a low saturation during intubation of 36 or less. Now, you'll remember that atmospheric oxygen is 21. It means like we're almost sucking oxygen out of the patient's body. These are low sats. And they're not brief episodes either. The median duration of hypoxia in that study was 2 minutes. That's 120 long seconds of hypoxia. And this was in an EMS system with an above average first pass success rate of 82. In fact, 70% of all desaturations occurred with first pass success. So what does that mean? Well, it means first pass success alone is not sufficient to prevent hypoxia. Now, I know a lot of my colleagues would have you think this is something that only happens in the field, that when that patient crosses the magical barrier into the emergency department, this never, ever, ever happens. Y'all know that, right? Right? Yeah, no, not so much. Unfortunately, it happens in our magic ERs too. This paper shows that in 166 emergency department RSI intubations, 36% of them experienced at least one episode of peri-intubation hypoxia. And of these, 93% were not hypoxic to begin with. So one thing I want to be clear about, and this is really, really important, these episodes of peri-intubation hypoxia, they are not a function of bad paramedics or bad physicians. It is really easy to admonish a clinician for allowing peri-intubation hypoxia, but it's unfair and it's self-defeating to do so. Please don't do that. As humans, we are prone to getting tasks saturated during critical events. Critical events like, say, intubating a sick patient. And just to be clear, we don't exactly intubate not sick patients. Well, that task saturation happens in the ER too, because humans. This 2016 Australian study of 100 directly observed ED intubations, they found physicians underestimated both how many patients had DSATs and how long the intubation attempt took. When asked, the clinicians felt like only 13% of patients DSATed, but the observers saw DSATs in 23%. They also completely lost awareness of time. They thought it took on average 23 seconds to intubate. In fact, it was almost twice that. This, again, is a function of being human, not of being a bad clinician. We're just not wired to both reliably intubate and monitor patients during an emergency. So we need to systematically change how we intubate if we're going to avoid this. And by systematically, I mean we need to change our systems. So the data we just discussed shows that peri-intubation hypoxia is common. But not only is it common, peri-intubation hypoxia is harmful, particularly in patients with conditions that don't tolerate hypoxia well, like, say, maybe brain-injured patients from TBI or from stroke. The odds ratio for death in these TBI patients with even one episode of hypoxia in this pre-hospital study was 3.9. Now that means the odds of death were 290% higher for patients with hypoxia than for patients without hypoxia. And this was not an isolated finding. It's not just a one-off study. There was a large state registry of TBI patients in Arizona, and they found the odds ratio of death in patients with hypoxia was 6-fold higher with hypoxia than without. This study also looked at the effects of hypotension, and they found that even one episode of hypotension was associated with a 340% higher odds of death. That equates to a 4.4-fold increase. Now, shockingly, the odds of death in patients with both hypotension and hypoxia, that was 13-fold higher than in patients who had neither. Hypoxia is also associated with hemodynamically significant bradycardia and cardiac arrest, like we discussed before. In an academic emergency department study, 2% of all RSIs had peri-intubation cardiac arrest, and over 80% were those from hypoxia. That means what happened to Mrs. Smith is not unusual. She got hypoxic, and this led to bradycardia, which led to hypotension, which led to cardiac arrest. So peri-intubation hypoxia is not only common, it's harmful. Now, you may have heard that intubation first-pass success is important. You may have heard me say that. Why is it so important? Well, because failure to achieve first-pass success is associated with an increase in adverse events. Well, what kind of adverse events, you ask? Well, I'm glad you asked that. The most common of these adverse events is peri-intubation hypoxia, the very thing we're trying to avoid. In a study of 1,800 emergency department intubations, the rate of all adverse events with first-pass success was 14%. Now, that rate increased to 47% with 2 attempts and 64% with 3 attempts. And as you can see, that is a very steep increasing curve. Take a look at this graph. You see that red line? That's the rate of hypoxia. That's the most common adverse event. 9.2% of patients with hypoxia, even with the first pass success. But that goes up to 38% with just 2 attempts. The odds of having an adverse event with each additional attempt goes up by more than 2-fold. Now, those are large odds ratios. Now, in addition to increasing the odds of adverse events, multiple attempts are also less likely to succeed. There is what I call a plateau point, above which further attempts are statistically futile. I did a study on this using a large pre-hospital data set, and what I found is for pre-hospital intubations using RSI, the plateau point is between 3 and 4, meaning after 4 attempts, further attempts are very unlikely to be successful. But as we've seen, each additional attempt comes at a clinical cost. So your actual attempt limit likely should be lower than that. And that's why we have limited the number of intubation attempts to no more than 2 per patient. Again, 2 per patient, not per clinician. It's our way of balancing the harm of additional attempts with the declining odds of success with each additional attempt. So if peri-intubation hypoxia is common and it's harmful, it sure would be nice if it were predictable too. Now, fortunately, that is often the case. If we look at this classic oxyhemoglobin dissociation curve, we can see how this is the case. Remember that the oxyhemoglobin dissociation curve is a plot of different pulse ox values at varying PaO2s, or partial pressure of oxygen. And as you can see from this curve, this is sigmoidal. In other words, it's S-shaped. It's not linear. It's not a straight line. And what that demonstrates is that the rate of desaturation is different at different points on the curve. If you look at the points where a PaO2 is 90, that curve is flat. Saturations are approaching 100%. Once the PaO2 gets below 60, and that roughly equates to a pulse ox of 90, itty-bitty drops in PaO2 are associated with huge drops in pulse ox. This is what we call the steep part of the curve. This physiologic curve manifests itself in our clinical practice. So if your patient has a pulse ox of 100% at the time of paralysis, they will slowly desat until they reach an SpO2 of around 93. And at that point, they desaturate faster and faster and faster. In other words, they fall right off of that curve. Now, if pre-hospital patients undergoing RSI intubation, 100% of them had peri-intubation hypoxia if their starting saturation was less than 93. This is an indication of how rapidly patients desaturate once they become hypoxic. In yet another study, patients with a starting sat between 98 and 100% had a rate of peri-intubation hypoxia of only 20%. So starting at 100% is no guarantee that you won't desaturate. You have to do other things in this bundle, but I'll take an odds of 20% of desat over an odds of 100% any day. So what this means is that patients with starting sats above 93 can typically tolerate a longer period of apnea without desaturation. This allows more time for a safe and controlled intubation attempt. So then it is predictable that patients with starting sats of less than 93 are at very high risk of peri-intubation hypoxia. In fact, this same study showed that 100% of patients with a starting sat of 93 or less desaturated during intubation, confirming what we saw with the other study. So preventing desat then is at least partially dependent on having good data on your patient's saturation, meaning you need pulse ox. Now, unfortunately, pulse oximetry data is not a foolproof technology. It has a tendency, especially in hectic intubations, to go walkabout. Of patients with TBI in this study who were undergoing RSI, 79% of them had at least one pulse ox dropout during the intubation. So what is a dropout? It means there was simply no oximetry value displayed. You're getting good data, poof, no more data, then good data again. Now, additionally, the actual value displayed, that's a bit delayed. In this study, 55% of intubations had an intra-attempt SpO2 low point, or nadir, that occurred after resumption of ventilations with oxygen. Now, we probably all experienced this. So you see a patient who is well saturated and you start to see the sats drop. You intubate and you have a beautiful end-tidal CO2 waveform. You visualize the tube going through the cords. You got great breath sounds. There's condensation in the tube. God himself comes down and says you are in the trachea. There is no doubt. Yet you continue to see the pulse ox drop. Now, that's not because the tube is in the wrong place. It's not because you're not using oxygen. It's because of pulse ox lag. There is just a delay between what is actually going on and what you're seeing on pulse ox. Now, fortunately, we can use this information to improve the safety of our intubations. First, do everything possible to assure the pulse ox probe is firmly affixed to the patient somewhere other than distal to the blood pressure cuff. And make sure it's not inadvertently dislodged. One of the things that we found early on as we're looking at our biometric data coming off of the monitor is that we would have this beautiful pulse ox reading and then we would lose it. And then it would come right back, beautiful pulse ox reading, and then we'd lose it. And then it'd come right back, beautiful pulse ox reading. Seemed very rhythmic, very cyclic. And that cycle just seemed to be occurring at a frequency of every 5 minutes. Almost like something was happening every 5 minutes. And it turns out that was the case. The pulse ox probe was distal to the blood pressure cuff, which was going up every 5 minutes. And we know that a blood pressure cuff turns into a tourniquet as the pressure is highest. No pulse, no pulse oximetry. Now, we have also found that little clippy thing for the pulse ox, it comes unclippied pretty easily. Whether you kick the wire or whether the arm falls off, it's easy. Well, the arm probably wouldn't fall off. Maybe it would fall off the arm. It's easy to become dislodged in any case. There really is no perfect technology, but it turns out that if we're aware of it, it will dramatically decrease. Not perfect, but way better. Also, by the way, don't wait to abort an intubation attempt until the sats get below 90. Don't wait for them to become hypoxic because pulse ox lag, they're already hypoxic. We have to assume that because of this pulse ox lag, the patient is already desatted by the point they get to 90. The safe place then to bail out of an attempt when pulse ox starts to drop is below 94%. To fully maximize pre-oxygenation, we need to not only increase the SpO2 to 94% or higher, but we need to keep it there for long enough to completely fill up the patient's physiologic buffer. So in most healthy patients, this physiologic buffer is filled up by normal tidal volume breathing for 3 minutes, breathing normally at a normal depth and normal rate. So we need to raise the oxygen saturation above 93 and keep it there for at least 3 minutes. So the point of this exercise is to replace the inert gas in the lungs and in the blood with oxygen. Now, because the atmosphere contains 21% oxygen and 78% nitrogen, our lungs and our blood also contain 21% oxygen and 78% nitrogen. Now, remember that nitrogen isn't doing anything for us. It's just there. If you breathe 100% oxygen, you will come close to getting rid of all of the nitrogen and replacing it with oxygen in about 3 minutes of patients who are spontaneously breathing normally. Now, this process of gas replacement is called denitrogenation. That term, denitrogenation, is often used synonymously with pre-oxygenation. Now, keep in mind, this 3-minute guideline is based on healthy patients. And as you probably know, we're not in the typical habit of intubating healthy patients. That means that while the 3-minute target is a reasonable starting place, it may not be the best measure available. In fact, it's not. Anesthesiologists measure effective denitrogenation by looking at something entirely different. They look at this thing called end tidal oxygen, or ETO2. That's the concentration of oxygen measured at the end of exhalation. It's the exact same concept as end tidal CO2, but with O2 instead of CO2. End tidal O2 values above 85% are typically considered markers of effective pre-oxygenation. Now, unfortunately, monitors that report end tidal oxygen, they ain't available in our environment. They ain't available in the emergency department either, for that matter. About the only places that I know that are actually measuring end tidal O2 in the emergency department are those doing research studies, like some of the ones that I'm about to tell you about. I'm hopeful, ever so hopeful, that we will be able to see this technology move into our field, hopefully sooner rather than later. So do me a favor, y'all. Do me a favor. The next time you see a monitor rep at a conference, they're showing off their new bling, please tell them, please add end tidal oxygen, not end tidal CO2. I know you got that already. Please add end tidal oxygen to allow better, more accurate pre-oxygenation and safer intubation. All right, so there's my plea. Hit up the reps. Maybe they'll give you some bling. Maybe they'll pay attention, but hit them up. Do me a favor, ask for it. Now, if the SpO2 level drops below 94% during the 3 minutes of pre-oxygenation, do something different to get the sats back up above 94%, and then reset your 3-minute time period. In other words, we need a full 3-minute period of sats at or above 94% to improve denitrogenation and to assure it. Likewise, if the sat drops below 94% at any point during an intubation attempt, bail out and do whatever is needed to get the sats back to 94 or higher, then reset your 3-minute timer before your next attempt. All right, so if peri-intubation hypoxia is common and it's harmful and we can predict when it will happen, how do we prevent that? Well, fortunately, the answer, it's not at all complex. You ready for this? Here you go. Stop intubating hypoxic patients. That's really it. It's that simple, not complicated at all. If you want to avoid peri-intubation hypoxia, stop intubating hypoxic patients. And that's the second point I want you to take away. Now, not intubating hypoxic patients does not mean don't ever intubate patients who were hypoxic. It means fix the problem first, then intubate. The common phrase for this is resuscitate before you intubate. I love that phrase, blatantly stole it from Dr. Weingart. Now, once you fix the problem, then continue with intubation. Frequently, this is a matter of taking some simple steps to optimize pre-intubation saturations. Now, while Twitter or X or whatever the hell it's being called these days may be a platform that is specifically and scientifically designed to raise your blood pressure and provoke rage, it also turns out to be the home of FOAMed. That's free open access medical education. One great example of the benefit of FOAMed was when Jason Cook coined the phrase sexy bagging, as in it's time to bring the sexy back to bagging. Now, that's probably not how that song goes, but I'm old and I'm a dad, and trust me on this, you don't want to hear me singing it. I don't know, maybe we ought to probably just move away from this. So back to sexy. Sexy bagging, that's just an acronym that describes several components of what I like to call a pre-oxygenation toolbox. So let's go over these components for a minute. S stands for second provider. Use a second provider when making a mask seal. E stands for placing the patient in ear to sternal notch position. X means the extra stuff that is available to you. And Y means have a Yankauer suction cath ready to use. So let's go through each one of those steps and talk a little bit more about them. Now, unfortunately, most EMTs and paramedics and unfortunately physicians are not adequately trained and don't adequately practice making a good face mask seal. We're all taught to use that one-handed EC clamp. So this instead of this. Please stop doing that. We suck at it. Don't do that. We should instead use the more effective two-handed thumbs down seal where your fingers are lifting the mandible up into the mask, not pushing down, lifting up, while your thumbs facing down toward the patient's feet hold the seal. This two-handed seal delivers higher tidal volumes with less air leak than the traditional one-handed method. Now, all too often when we realize we don't have an adequate seal, we simply press the mask down harder onto the patient's face. This is counterproductive. It presses the mandible posteriorly, inadvertently occluding the airway. So, lift the mandible up, don't push. Lift, don't push. Lift, don't push. So that's making a mask seal. If the patient needs assistance with ventilation, you have one person making a good two-handed seal and a second person providing gentle ventilations. So that's the S. E is for ear to sternal notch positioning. Proper positioning is key to effective ventilation, oxygenation, and intubation. If you elevate the patient's head and place them in an ear to sternal notch position, this has the neck extended and the face parallel with the ceiling. The ear canal will be level with the sternal notch, just like you see in my buddy Kevin in this picture. Now, because I like to think I know my audience, I'm pretty sure there's another way of describing this situation that might paint a better picture. Picture this, if you will. Say you and a friend, maybe a colleague, maybe after a long shift, after your shift, just to be clear, after your shift, maybe y'all are in a pub and you got a fresh pint. Now, you don't want to spill that precious beer. So what do you do instead? You got the beer, it's full. You extend your head toward the beer instead of just tilting that pint back toward your head. This is what I call the pint sipping position. In reality, it's just a vertical ear to sternal notch position. I just like the phrase better. Because we come equipped with all manner of equipment to aid our patients, we should use these extras that include lots and lots of oxygen. Y'all may have heard that too much oxygen can be harmful. While this may be true in some circumstances, it does not apply during pre-oxygenation. They need all of the oxygen. Give them as much as you possibly can temporarily before and during the intubation process, and then titrate down to the lowest fraction of inspired oxygen, or FiO2, that you need to maintain your oxygen saturation goals. Use one oxygen source for the BVM and then a separate oxygen source for a nasal cannula. Turn both sources of oxygen up as far as the regulator will go. Now, if you're a Spinal Tap fan, I want you to go to 11. If you have no idea what I mean, just go search it on YouTube. Spinal Tap, great satirical movie. But in the meantime, just turn the thing up as far as it'll go. Now, on many regulators, that means you can actually go past whatever the highest number on that regulator is, especially the little ball things. Just keep going until the thing doesn't go any further. Now, using a nasal cannula under a BVM, it does two things. First, it provides an extra source of oxygen to further increase the delivered FiO2. And most importantly, it allows you to easily transition to apneic oxygenation during the intubation attempt. So why do we do that? Well, we want to continue giving oxygen, and it's really hard to get a laryngoscope blade through a mask. That's not an option, but the nasal cannula is. Now, speaking of extras, waveform capnography, also an extra. Use it before, during, and after the intubation attempt. Now, in addition to confirming tube placement, we know that waveform capnography can also be used as an indirect measure of tidal volume. Now, we typically try to assess chest rise to judge the adequacy of ventilations. Let's be honest, guys. We're in Texas. We got McDonald's everywhere. Our patients are getting kind of big. You may have noticed this. We're making some big boys out there. Truly judging chest rise, it's a bit of a crapshoot. Waveform capnography, on the other hand, that allows us to estimate tidal volume really nicely. Use it. It also, again, to reemphasize, is the most sensitive and specific means for verifying ET tube placement that we have. It's just the best thing we have. It's the gold standard. Now, if you don't have waveform capnography after you've intubated a patient, you most likely are not in the trachea, and you got to pull it. You got to do something else. That is a red hot danger zone. Pay attention to your end-tidal CO2. Next extra is a PEEP valve attached to your BVM. With PEEP attached and on and at least 5 centimeters of water with apneic oxygenation, all BVMs are capable of delivering oxygen without squeezing the bag. So why do we care about not squeezing the bag? Our goal is to avoid squeezing the bag in spontaneously breathing patients who have adequate tidal volume, because doing so leads to increased intrathoracic pressure, decreased cardiac preload, and lower blood pressures, and more gastric insufflation in the stomach. Those are all bad things. We don't like those. Avoid them. I do, however, really want to emphasize something here. We're only avoiding squeezing the bag in patients with adequate spontaneous breathing and adequate tidal volumes. Obviously, if they need to have assisted ventilations, by all means, do so. Assist their ventilations. Gently squeeze away at a controlled rate. If you're still unable to achieve adequate saturations despite good tidal volume, despite maximal oxygenation flow through 2 sources, despite a good seal, despite good positioning, despite airway adjuncts like nasopharyngeal airways, oropharyngeal airways, despite an adequate respiratory rate, if you can't get the sats up despite all those things, start bumping up the PEEP. Now, this often increases alveolar recruitment sufficient to raise saturations. Now, in this short video that I found online through the magic of my really strong Google foo, demonstrates the impact of increasing PEEP on lung recruitment and what happens when you turn PEEP off. This is a video from sheep lungs that were specifically prepared to demonstrate the effects of PEEP. Here we're bagging the patient without any PEEP at all, and just for the sake of demonstration, not that we're going to do this clinically, I'm going to turn the PEEP all the way on. And what you're going to notice is that the lungs are slower to collapse between breaths. That's the alveolar recruitment that we get from PEEP. And now I'm turning the PEEP all the way off. And what you're going to notice is that the lungs completely collapse. That's what PEEP is doing. Now, moving on in our sexy acronym, another common cause for failed airway attempts are secretions. You know, vomit, beans, tacos, beer, blood, that stuff. That frequently makes intubation way harder. Fortunately, we have suction for this, provided it's available, provided it's turned on, and provided we have a catheter with a great big hole. We don't want itty-bitty catheters here. We need Texas size units, big honkin' catheters. So when we're using the sexy term because we want it to mean something, that Y stands for yanker. We typically use that synonymously with any suction cath, but we really shouldn't. Not all suction caths are created equal. And this is something your purchasing officer needs to know. We want a large bore catheter for all that industrial strength airway crap we come into contact with. Now, I'm a big fan of the Decanto catheter, and I highly recommend it, despite the fact that my friend Dr. Jim Decanto does not give me a single penny in kickbacks for recommending it. I'm deeply upset about that. But it does work really well. It's just the right tool for the job. All right, y'all, so those are the sexy bagging tricks. That's what you have in your toolbox. Please use everything in your toolbox to adequately pre-oxygenate your patients and prevent peri-intubation hypoxia. Now that we've gone over the components of the toolbox, I'd like to go over the evidence for those components now. We know that placing the patient in a heads-up position improves the percent of glottic opening. That's called POGO, percent of glottic opening. Now, Dr. Rich Levitan did this study and showed as the head elevation increases, so does intubation conditions get better. Let's go with that. Head elevation also, it turns out, prolongs safe apnea period, delaying the time until SpO2 begins to drop. That's good. Now, in this study of healthy OR patients that have been adequately pre-oxygenated and paralyzed for their normal surgery, patients with the head elevated by 20 degrees took longer to desaturate down to 93%. In fact, they had over a minute and a half of extra safe apneic time just because their head was elevated. Well, how should we best achieve pre-oxygenation? Well, by using a BVM or non-invasive positive pressure ventilation. These provide better pre-ox than a non-rebreather mask. In this paper by Groombridge, healthy volunteers were randomized into different groups that represent common pre-hospital methods of pre-oxygenation. The primary outcome was FeO2, and that's the fraction of expired oxygen. It's similar to end-tidal oxygen that we talked about earlier. Now, as you can see, both BVM and non-invasive ventilation performed much, much better than non-rebreather mask. That's why I want us to use the BVM. Using a nasal cannula under BiPAP or CPAP, turns out it does not increase air leak in a significant way, and it eases the transition from pre-ox to apneic oxygenation. So using BiPAP, CPAP, or BVM with flush rate oxygen and PEEP improved pre-oxygenation, and there was less peri-intubation hypoxia compared with non-rebreather mask alone. That's good. Now, in this study of critically ill hypoxic patients in need of intubation in a French ICU, patients were randomized to pre-ox with either a non-rebreather mask or non-invasive ventilation using a ventilator. The group with non-invasive ventilation had higher pulse ox values at the time of intubation. They had higher pre-intubation and peri-intubation low sats, and the higher sats persisted up to 5 minutes following intubation. Good pre-oxygenation really works. Implementing a bundle of care aimed at good pre-oxygenation, that was associated with decreased rates of DSATs in this helicopter EMS study, down from 58% to 14%, and it improved intubation success from 89% to 98%, most likely because it de-stressed the situation. Maintaining a pre-ox sat of greater than 93% for more than 3 minutes, just like we've advocated, was associated with a 380% higher odds of first-pass success without hypoxia. Very, very good. Well, speaking of apneic oxygenation, let's take a look. Turns out it works. It was associated with decreased DSATs in healthy OR patients. Let's talk about this slide because I love this slide. This was a study that Dr. Scott Weingart first made popular when he was talking about DSI, and I think it is incredibly informative. This study took healthy patients who were undergoing surgery for something. They paralyzed them just like they normally would. They intubated them, and then rather than ventilating, they just grabbed oxygen delivery tubing, put it in the ET tube, and cranked up the oxygen. No ventilation at all. And the goal was to see how long it would take them to desaturate. Now, looking at this table, you're going to notice some of those times are up to 55 minutes without any ventilation. Now, you may notice that these patients did not desaturate. The SATs, they never got low. Take a look at those pH values. Man, they are all under 7, and that is bad. Look at those CO2 values. Those things are really high, and that's what's driving the pH down. Bad, bad, bad. But it's not a reflection of poor oxygenation. Remember, apneic oxygenation works. They didn't desaturate. It's a reflection that we really do need to blow the CO2 off at some point, just not within a couple of minutes. The oxygen sat drops way before elevated CO2 becomes a problem. So for the love of all that's holy, please don't try this experiment at home. But the reason I show it to you is that it demonstrates that if you're just looking at maintaining pulse ox, apneic oxygenation can do that. And for the time it takes us to intubate, that's exactly what we're looking for. We want to prolong that safe apnea time to allow us to make a safer intubation. So how does it do that if you're not forcing air in and they're not sucking air down? Diffusion. It turns out Brownian motion gas law works. The oxygen will diffuse from an area of high concentration to an area of low concentration. Now, one other thing about this, notice this study. This study was published in 1959. This is not exactly earth-shaking, breaking news science. But I do kind of doubt we're ever going to see something like this again. There is no IRB in the world that's going to approve this study today. Honestly, that's probably a good thing. I don't think it was ethical to do this study. But I'm glad we have the results. So apneic oxygenation is also associated with 120% higher odds, a bit over twofold, of first-pass success without hypoxia. It also decreased the rate of peri-intubation hypoxia from 29% to 7%. We like that. We're trying to avoid peri-intubation hypoxia. Apneic oxygenation, it works. So in this systematic review and meta-analysis, apneic oxygenation was associated with 34% lower odds of peri-intubation. That is a good thing, my friends. All right, let's get to delayed sequence intubation, or DSI. DSI is the process of giving ketamine followed by a delay in giving the paralytic to allow for better pre-oxygenation. DSI improved the SpO2 from 89% after maximal efforts at pre-oxygenation up to 89% in this 2015 study of ICU patients by Drs. Weingart and Truger. This is the paper that put DSI on the emergency medicine and EMS roadmap. So DSI has been successfully used, obviously, in the ICU, in the ER, and in EMS. We adopted this protocol, the same protocol we're adopting here, when I was in Williamson County. We experienced a sentinel event with a critical patient that involved peri-intubation hypoxia, bradycardia, and cardiac arrest. That sentinel event may, theoretically, hypothetically, may have been very similar to a case you might have heard at the beginning of this talk. At Williamson County, we then underwent a quality improvement project aimed at changing the environment, changing the culture, changing the processes around intubating non-arrest patients. The aim of this project was to prevent peri-intubation hypoxia. First, we went back and looked at our data to make sure this critical event wasn't a one-off event. And it turns out it wasn't. It was not isolated. In fact, 44% of our RSIs had a peri-intubation hypoxic event. We found 2 additional cases, as a matter of fact, of peri-intubation cardiac arrest, and that put us right in line with the existing literature on how often this happens. The literature, once again, says that between 2 to 3% of all intubations end up in cardiac arrest, and almost all of those are driven by peri-intubation hypoxia. So we implemented a bundle of care that consisted of a mandatory checklist-driven protocol that included proper positioning, goal-directed pre-oxygenation, apneic oxygenation, and DSI for all non-arrest intubations. Positioning required that the head of the bed be elevated at least 30 degrees and that the patient be placed in an ear to sternal notch, or as I like to say, a pint-sipping position. Goal-directed pre-oxygenation, that means we used a BVM with PEEP valve and a reservoir with flush rate oxygen, of course, held with two-person thumbs down seal, lifting the mandible, not pushing, and achieving an SpO2 of 94% or higher for at least 3 continuous minutes. We use nasal cannulas to increase to flush rate after sedation with ketamine. So give them the ketamine, turn the oxygen all the way on. That's really what we mean by DSI. Now, DSI was performed with ketamine and rocuronium in all of our patients, and if we couldn't achieve goal-directed or goal saturations, intubation was not allowed under any condition. If the patient needed airway protection rapidly, or if we couldn't hit our pre-ox goals, then they aborted the attempt and moved on to a rescue supraglottic, using rocuronium if needed, but they went to a supraglottic. Now, the reason, and I get this question a lot, the reason for placing a blind insertion device like an iGel or an AirQ or a King LT is that they're faster than intubating. And there's good literature on that. And they're also more successful. And the patient is less likely, therefore, to have a rapid desat. So we published the results of this QI effort at Williamson County in Annals of Emergency Medicine in 2018. I'd like to tell you a little bit about it because this is the experience I expect us to have here And I might add, in our trial, it is exactly the experience that we had in Williamson County. So we looked at 104 intubations that were done before we implemented the bundle, and we compared them to 87 intubations done after. The patient characteristics of these two groups was very, very similar. The primary outcome of the study was the proportion of patients who experienced peri-intubation hypoxia, and that rate, the bottom line, that rate dropped from 44% to 3.5%. After we implemented the bundle, the 25th percentile peri-intubation low, that increased from 74% up to 96%. That's really good. The rate of bradycardia, it decreased from 18% down to 2%. We graphically represent this change in pulse ox at the beginning of the attempt and the low sat during the attempt. This representation is what we call a waterfall plot, and I'm really proud of the code that we wrote to make this, so I'm going to share it with you. Each intubation is shown on this graph by 2 points connected by a line. The top dot is the SpO2 at the time the intubation began, and the bottom dot is the lowest the pulse ox got during the attempt. Basically, the longer that vertical line, the more desaturation there was. And you're going to notice that there are far more desaturations, far longer lines occurring in the blue before group than in the red after group. So our experience there clearly demonstrated that paying attention to the details of intubation, particularly achieving adequate pre-oxygenation, proper patient positioning, apneic oxygenation, goal-directed oxygen saturations, and DSI, can definitely statistically and clinically significantly decrease peri-intubation hypoxia. Now, that's not the only way to achieve this goal, but it worked really well for us. It's worked well for others. And as I said before, it's working well here too. We've now completed 14 intubations using this protocol during our trial here in Fort Worth. We've seen above 95% first pass success without hypoxia. Now, I just heard this morning that we had 2 additional DSIs last night. Both of those were first pass successes without hypoxia also. So when I say that we're going to intubate right or we're not going to do it, this is what I mean, y'all. And it's why I'm confident that we can do this here too, provided I give you the right tools. I don't think we were doing it before because we weren't giving you the right tools. I'm convinced these protocols are the right tools. I think you're really going to like this approach. The trial data is good. People involved in the trial really like it. And with it, I know that we can collectively assure there are no more cases like Mrs. Smith. Please, please join this crusade to make intubation safer by avoiding peri-intubation hypoxia. Thank you all very much. Thank you for everything you do every day to better serve the citizens of our community. Thanks again, and take care, y'all.